Okay, we'll get to go at 9 o'clock and 9 evening. We have. Very much. Right, good morning. You're all very welcome. Public health meetings of Northampton General Hospital. First of all, to remind everybody that the meeting is being live broadcast on Zoom and YouTube. It is also recorded, so you can see it for a long time afterwards if they really can't sleep. But so beware that your screens in particular may well be on camera. We have welcomed to Annette Whitehouse, who's the new non-exec, joined us on the 3rd of January for a 2-year term. We welcome Debbie back into NGH. She sat here a while before, but we used to have the board table the other way around in those days. But anyway, as interim group CEO, we welcome Natasha as the group chief digital information. Probably ought to congratulate Hemant as well on being substantively appointed as medical director at Northampton. I'm sure you'll absolutely superb in the role. What else do I have? And I have apologies from Simon, Debbie Shanahan, which is my own Ledbetter here. And Heidi is somewhere in the ether up there because both her children are not very well, family health problems. She will be joining us at lunchtime for the private board session. She's got everything arranged and set with the family. So she will be back in about lunchtime. In the meantime, Palmer will be handling her items on the agenda and orchestrating, comparing the IGR session. So, Chairman of the committee, you've got to be really nice to really precise. Otherwise, he will tell you to speed up. So, right, we have a staff story, winter pressures, which on my agenda is Heidi to introduce us. Here, you are.
So, just so everyone's aware, we made a huge amount of effort planning as a system of trust going into the winter. However, I think you will agree, seeing the national and also the local picture has been really, really difficult. So I think it's really important that we hear from some of the team who are working in ED and urgent care over that period. And just to put it in perspective, we have an ED department built for 45 during COVID with the spacing. It's around about 65 capacity at the moment. We would often have over 140 patients in there over the November-December period. With over full tilt, we had over 60 people turning up in 2 hours. So that's the full capacity turning up in 2 hours, just to give you an idea. So with what we have here today, we've got Sarah Bates, one of the ED consultants, a matron for urgent care, Kirsty Palmer, and we've got Ruth Smith talking from a patient point of view and a carer coming through with one of her relatives. So I'll hand over.
Thank you for inviting us today. When we were asked to present, we were asked to talk about the daily life of urgent care, but as is typical of urgent care, every day is different and every person in the team is different. So instead of that, we wanted to focus on what our challenges have been. And I don't think I need to tell you that the news headlines about ambulance waits and trolley waits have not been exaggerated. We very much experienced those here at Northampton. I've been qualified for 18 years. I've worked 17 of those in emergency medicine. I've never had such a difficult winter. It has pushed myself and the team to the limit. I'm really proud of the team that's been around us. They have been so agile and so responsive. They changed their working patterns literally in 10 minutes notice. So I'm going to go through what those daily challenges are. Let's talk about the impact that's had on the patients, the impact that's had on the staff, and what we've done about it to try and improve things. So the first thing is grounding. As Parks mentioned, we should have around 60 patients in our emergency department capacity, but in the early evening, almost every day over winter, we've had between 100 and 120 on a normal day. That's partly because of high inflow. We've made huge investment in the streaming process, and that's been fantastic. We've had more streams at the front door. These are senior clinicians, and they're able to divert patients who are self-presenting to alternative sources. Springfield, our urgent treatment centre, has been such a backup for us. They've taken huge numbers of patients, meaning that those patients aren't sat in our waiting rooms. SBEC has also been fantastic. We've actually increased their working hours. They're now open to midnight. So they're able to take patients that are expecting GP referrals that are going straight to specialty. So again, that's fewer patients sat in our ED. That means we're just looking after the ones that really need to be there. Exciting plans for the future are the UTC hub that's in the planning stage. That will again extend our capacity to keep people out of the emergency department for them who don't need emergency care. The big story is less about inflow for me in the shop or in the emergency department and more about outflow. Because of the lack of beds on the ward, we've had a huge increase in length of stay. The number that horrifies me most isn't the trolley waits, it's those who are sat in chairs. And every single week, there are people who are sat in chairs with chairs. And I just don't recognise that as the health service that I've trained in and 13 months. It's meant our staff have had to learn new skills. It sounds silly, but we've had to learn to do drug rounds. We don't have to do that in emergency medicine. Our drug and storage facilities aren't designed for all patients needing drugs at 8 o'clock in the morning. We've had to learn about new things like deconditioning. The deconditioning aid has been a great tool to help us upskill in that, thinking about getting our patients moving and exercise. A consequence of crowding has been that we've had to stop visitors, and that's not all because of COVID rules. When the COVID rules relaxed, we've not physically had enough room in our waiting areas to allow patients to move visitors. If your loved one was unwell, you would want to be with them. And because we've had to stop visitors, that's caused quite a lot of aggression at the front door that the screening team and the reception team have to deal with because people don't understand. We've tried to be agile and we've developed stickers so patients who need to have a visitor with them, for example, somebody with dementia, somebody with a disability, it makes it very obvious to everybody in the waiting room that sticker on that person is exempt and they don't have to keep being challenged by staff and asked to leave. Resource capacity has been overwhelmed almost every day. Making dynamic risk assessments when you're running resource is absolutely exhausting. It feels like you can never make a good decision or just making the least worst decision about things. We're caring for patients in non-clinical areas, corridors, they've got extra beds on the 9-bed unit, and when you're caring for somebody in a non-clinical space, you lose dignity. The real problem for us as doctors is how inefficient we become when we're full. We really try to protect walking cubicles so those patients in waiting areas can still be seen when all the cubicle spaces are full. But the reality of this winter is the moment somebody in the waiting area gets diagnosed with flu or COVID unexpectedly, they have to take in one of those walking spaces to protect everybody else in the waiting area. And when you have no cubicles, you cannot see your patient. You can't listen to their chest, you can't do an ECG in the waiting area. So we almost grind to a halt and throw in doctors. The problem in that situation doesn't get our weights down. It's so frustrating. We've had significant delays in ambulance handovers. That's never happened to me here at Northampton until this last year, really. And we feel the weight on our shoulders that every ambulance we hold, we know is not going out to 911. And we know that, we feel that's a responsibility when we're trying to get these patients presented, but there is no left. There was an EMJ, Emergency Medical Journal article published in January last year, which was powerful and distressing to read. They looked at data collected nationally for all type 1 EDs between 2016 and 2018, and they made a correlation between long waits in ED and increased 30-day mortality. They showed that for every 82 patients waiting beyond 6 to 8 hours, there was 1 extra death. We routinely have, across the country, there are people waiting between 6 to 8 hours. There is harm coming nationally because of these waits. What's frightening is that back in 2018, when they finished data collection, 12-hour waits were normal. Don't know what happened. We've seen harm increase in our department. The number of SIs has gone up, which is completely predictable when we've got more patients and ambulances. But what absolutely baffles me, and I can say with pride, the amount of harm we've had in our ED is not what was predicted. We have less harm than should have been predicted. So how do we manage that? It is something we should be proud of. Well, we've increased our staffing at the front door. We've got more HCAs. We've got a HCA working on the front door doing observations. So we can have a news score literally from the moment they arrive. That means we can pick up our sickest patients a lot quicker. We've had an uplift in our staffing, both nurses and HCAs. We've increased our registrar cover at night, and very helpfully for the ambulance delays, we've got an extra senior clinician who works in our fixed area. So when patients are held on ambulance for more than 30 minutes, a clinician will go out to them, senior decision maker will go out and review them. They have blood tests on the ambulance, they have CT scans on the ambulance, but even now they ultrasounds on the back of the ambulance. So if we can't get them in, we go out to them. We've had to improve our governance for that, so we've created new documentation that helps us record what we're doing in the ambulance, but also access the public front. We're holding ambulances on our worst days, which is incredibly stressful. So that includes the fronts, that things like being reviewed. We've increased things like the hostess cover. We can now get hot food from patients 24 hours a day, 24 hours a day. The volunteer service have been amazing. They are now covering an 8 to a later service. They go around, they chat to patients who are distressed, they make up a team. They've also started some activities for me so they can take around covering crosswords, word searches. We've got new clip kit, we've got recliner chairs, and we've now got oxygen concentrators for waiting areas, so we don't have to worry about oxygen cylinders running out. And we've got a frailty activities coordinator that's been funded by Northampton carers to help with arms with dementia. Keep their brains active. What we really need in the ED is flow, and Northampton have been incredibly responsive. I'm just going to talk a little bit about what Northampton is doing. So Northampton, as you know, are two assistant areas within urgent care. The team have been really dynamic in trying to support flow. Pulling their patients out, creating extra spaces in their days. Patients would be asked to do, and within that, it's really difficult to maintain consistency. Within the last 12 months, we created our taking sort of our own now, which is fantastic. And that's really helping with the team building, continuation of care, just making sure that our staff is within the unit that we like. And we've seen massive achievements with that rather than relying on locals. We've had lots of engagement with them and our nursing staff around quality improvement projects. So that's been supported by ESIS, which low early discharge. Again, everybody's been really engaged with them. We've recruited 4 flow coordinators, patient flow coordinators, and they are around just using discharges are they're not the sort of thing that urgent care used to deal with. So they really help us to support with the complex discharges and transfer care into created delay any transfers or indeed care, sometimes 72 hours. So it's that time to try and get patient services, coordinating care with the doors. So again, that's really trying to empower patients with fixed discharge home within that 72-hour period. I then sent support with nursing staff, bonus, and that's our total taking that post and down in the office, nurses going around. So we would be doing the night there. If we had low, to make sure we're not missing any discharges and patients get them care. The team has been urgent care as a whole, and really engaging with their activities and the main events. So we can put anything out the back of the to try and make things better. We've also been running a CMDU delivery unit from 9/11 also, which is really looking at patients at high risk. And if they were to get COVID, and when they've got high risk patients, then we give them treatment to deterioration and hospitalisation. Just also wanted to talk to you a bit about staffing. So the increased number of patients that we have, unfortunately, our staffing has suffered. We're currently running the emergency department, particularly challenging, running the nurse vacancy of 36% and an 18% HA. The team have done lots of work around movement. We've always got job adverts now, unfortunately. And we've been having some support from a lot of the overseas nurses, which is great. We're doing over there. Got 17 nurses starting the next months. Within the trust of absolute support in urgent care with our vacancies, every morning we hold a senior team meeting. That's morning and afternoon, and the trust will support us by sending nurses to other areas. and we also rely on radio agency. Within this, it has got its own challenges, as fantastic as it is, because it's delivery of care and obviously ensuring that the staff are aware of what our expectations are. So that within that support, there is. The question is why? Why do burnout is a massive issue. Staff, because of the shift vacancies, shift responsibilities, and it is constant. The minute you get in the morning to the minute you get home at night, there's no letter. All day or night with no rest really, and break time, even getting our breaks. Moral injury has been huge teams because we're so full and the pattern of patients all day. It's been a lot. It's been really difficult. We're not being able to give the care that we would expect to be able to give, or we would like to give to the broad person. We have, as Sarah mentioned, violence and aggression has been an issue because the wait time is longer and patients are frustrated, and that's also been an training has been involved quite regularly from our teams, and that impacts on their feeling of self-worth. We absolutely will value them. It's their feelings of self-worth. We don't just keep up to date with their training, and that's purely down to the fact that we've been on a shift and we've got 10 vacancies in EG. We can't have 10 vacancies. Training session need to keep it service, so it's really to try and manage that. So I just want to talk a little bit about what we've done to support our teams. So with regards to the temporary staff, with the animal and the animations, there's a role out for everybody, so that they're handed them in the shifts and then the expectations. We're doing a recruitment on the 11th of March, so I'm really getting some interest in our area, where a lot of our teams will be going and rallying around and trying to get as many people as we can. SOF have been a fantastic support, so they've been wonderful through COVID last year. They've done individual sessions and group sessions with our teams. Security is now present at the front door, which is visual and support for our team and to tell us patients and when they are feeling frustrated. And we've got a trial of bodywork cameras from start in March. That gives support now our senior team with mainly as a terrible. The issues with staffing isn't just isolated. The highest number of junior doctor resignations in the last 12 months I can ever remember. To try and improve that situation, we've introduced a CESAR programme, and this is really good for retaining middle grade doctors. This is allowing middle grade doctors to show consultant level competencies and achieve consultant status throughout their training programme. That's something that we're looking at future as a new business case for our staffing. For doctors, we really struggle on weekends. So we're limited by the National Junior Doctors Contract about how many weekends we're allowed to work them. So that means that weekends we have to rely on local and agency staff. With the money we are spending on local and agency staff, we can spend that much better on substantives. Something we've been really trying to work on improving morale. People are leaving because they don't feel they can do a good job and are frustrated with the level of care they're delivering. But if they feel valued and if they feel a member of the team, I hope they will want to stay. Things we've done are have team days, and so we've been bowling together, we've had team debriefs together off sites. We've even had movie nights that were set up by Tristan, where we've been to the cinema as an urgent care team. We've had dog walks, bike rides and climbing group as part of our staff conditioning games. We've now even got a craft group, and we had our second session this week where we learned Indian block printing. So I feel really proud of those activities because most socialising in the NHS traditionally involved alcohol, and that isn't good for us, and it's not appropriate for many of our doctors. So I think we've really put it at the back on those things. They've helped me. I just wanted to make you aware of a few achievements that we've made. These are our most recent achievements. So even with all the pressures that we've been under, Walter Tull and Esther White have done fantastic presentation. The standards of care, such as evidence that they're achieving great standards of care, even with all the pressures that are going on. Walter Tull achieved blue last month, and Esther White due to those in Florence. Nigel Evan and Andy both achieved awards at the decondition games, which is really supportive of our patients and our staff.
And then I just wanted to share with you that we have had 14,683 positive comments in the last 12 months, which I think is amazing for the strength of the challenges of the under. I was going to share some with you, but I'm conscious of time. But I just wanted to say that it's patients and relatives, resounding feedback, it's patients and relatives are very understanding and aware of the pressures the NHS is under. And the overarching feeling that comes through is just they are so grateful. Amazing.
I'm going to close on an analogy, so please bear with me. I feel like the NHS emergency care system, we've all been in this river and we've seen the waterfall approaching, and we've all been swimming like mad for the last 5 years to stay away from the edge of that waterfall. When COVID hit, we had to swim harder and we had to learn how to swim, but we kept away from that waterfall. And I feel like this winter, the whole urgent care across the NHS went over the edge of that. Many EDs are in a much worse position than us, and they've floated down the street and they're in real trouble. We are also in trouble, but we are still swimming. We can see the top of the waterfall, we know where we need to be. I'm going to be honest, I don't know all the answers of how to get up there, but we're still swimming and we are moving forward. Thank you, Kirsty.
So I'm extremely proud to be an employee of this trust. Obviously, I'm here today to love what we've had in December. One Friday in December, knowing that the hospital was in an extremely precious operational position, I got a call from a relative who recently received a diagnosis of terminal cancer with a 3-month prognosis. He suddenly become very acutely confused, disorientated, and in favour of We made a call to EMAS. They were extremely supportive, but advised that it would be at least a 6-hour away. Obviously, whilst my relative wouldn't have been candidate for bronchiolitis, but the stroke was the case, he would have already passed the 4-hour window for that treatment before he would be able to arrive in hospital. 6.5 hours later, first responder arrived and made their hospital with extremely high blood pressure, also indicated a stroke. NGH1 diver at that time, but after assessment, as my relative absolutely scanning, 7 ambulances were transported into Reading. The ambulance arrived at 5:13 a.m, 8.5 hours after the 999 call. I went back into ED the following day around lunchtime to check on them and see how they were. They were in acute becoming fit stop, having been seen by a doctor waiting for scan. I asked the nursing station when this was likely to be done. He was uncomfortable, his mind was exhausted, but very frightened about the whole experience. Staff were extremely helpful, but said unfortunately he couldn't go for a scan as no one was available to escort him. So I offered to escort him, and about 15 minutes later, an extremely helpful porter arrived and we went round to see it. About half an hour later, a junior doctor came to the stop cubicle and announced the confusion was not due to a stroke, but instead of influenced by swelling around brain that we did not know that he had. Give me if I get a bit of you. The doctor was compassionate, was there for only a few brief moments. They had to leave us to see the other patient. My relative was able to try and process that on them. After an overnight stay in the J bed and a transfer to Watertop with fantastic palliative care support, my relative was able to be discharged home with what was going to be his last memory. Throughout every step in this admission, the weights were excessive, the information was limited, staff simply weren't available to answer those questions. My relative with terminal cancer waited over 8 hours in an acute state of confusion from phoning an ambulance to arrive at ED with a further 7-hour wait for a scan. Staff were extremely stretched and every single centimetre of space in our ED and its joint corridor was full. However, whilst our department is overcrowded, staff were exhausted and the pressure is unrelenting at every single step in our journey through that department. My relative and ourselves were that cost us so well. We received the very best medical care. Our exhausted staff still had the energy to smile and to care when they were with us, and they continually apologised for the ways that we experienced. There was nothing they could do about the challenges outside of their control. They absolutely could not have done more for us for the things they could control and the care that they gave us. And I absolutely welcome this opportunity to back in the public forum for what they did with my rest of that.
Apologise. Doing that. Respect. And thank you for telling the story of what happened this week. I'll come back to comments, thoughts, or anything else on the field.
Thank you so much for your presentation. You obviously talk a lot about Vision Care and all. So thank you. Thank you for this amazing patient experience, which helps us understand it from the heart as well as the head. I wanted to take the opportunity to raise this later on in the board. Because in both the group chief exec's report before us and the trust chief exec, we are thanking staff. I doubt very much whether many staff read our board papers, to be honest, and I did wonder if there was anything else that we could do to express our thanks for such commitment, which is just amazing, all the things that you're doing. So absolutely fabulous. So that was the first thing. The second thing was whether we could do anything more to help, which is probably unlikely given the scrutiny that everybody's support's been given to the department. But one thing I wondered about, historically over the years, recruitment into vacant posts has taken a while, and I wondered how that was going for your department, because sometimes it can take 2 or 3 months to get somebody into places that anything we're looking to facilitate that. And then thirdly, I'm looking at Andre now as chair of our governance committee, quality governance committee. We have had really good scrutiny of what happens in your department. So initial assessment after arrival, pain scores, the continuity rounds, and we've been amazed at the results that has given us and we've managed to do it. So that's absolutely fabulous. But I suppose it's to assure the board that we are looking at this very careful quality perspective, the second one that you are. And yesterday we had learning from deaths group. We're just beginning to scrutinise the extra deaths. I think you mentioned this, didn't you? We've only just got the data for December for our HSMR, and the shillings 2 or 3 months back ago, so we'll just see. But we are scrutinising it, and we've asked Dr. Foster, who would with our mortality information, to focus on that for us. So, so for the board, I think just wanted to say that we are really looking at this. And is there anything else that we can do to support them?
You just hold those thoughts. Anybody else want to comment? Janine's an angel.
Yeah, I mean, obviously, you know what Jim said in terms of thank you very much, and all of the teams. Really humbling, to be honest, to hear that. And I think my question really follows on from one of Jill's, and that's you mentioned at one point there's a lot of things that we've done, and you don't feel that you've answers, all of the answers, which we don't expect you to have all of the answers, obviously. But if we think about the things that are within our control, do you feel that there are things that we're not doing that could be done? And also, more importantly, moving forward, do you feel that there is a route for you and your staff to be making suggestions that are taken up in terms of improvements? Because when you're in a situation on a day-to-day basis, you can see things where it's like, well, why do we do it like this? Why do we have to do that? You know, have you other things that you don't think that you're doing that you could do, and do you have that route to raise this and be listened to?
One word. Test your memory too much. Well, I promise not to test your memory too much. Some of them will call us anyway around the what questions, John.
So thanks for a very honest, assessment, insightful assessment, and clearly very emotional. And thank you for sharing. You referred to, if I had it right, the highest turnover or kind of leaving of juniors within the department. In your experience, we'll clearly understand why they've gone. Do we understand where they've gone to, and whether or not that's something that we could do something about? So you've clearly done a lot of work around trying to build and maintain team spirit in an almost impossible environment. but that kind of wider, have they jumped ship because of us, or have they jumped ship because of ED, full stop?
So, two of the questions were, what can we do? I don't have the magic answer, but what I do feel like is that when we ask the questions, they do get listened to. So when we submit our business cases, when we present it, when we are asking questions, something that I wanted to say about the team, which I forgot to say, was the reason I was staying at Northampton is because I feel like we have got a good team, and that's not just within urgent care. I worked at ATDs and I've never had such a positive relationship with the site team. And every other hospital that's been adversarial, they are not giving us beds. We work really well with site team. That might be because they've got quite a lot of our senior nurses. That teamwork really helps. And so when I was filling my NHS survey, staff survey, I was able to say, I do feel listened to, and I think my best. I can't emphasise that just this week. So there are things that we're working on in the future. There aren't any magic things that I could give you a short list for now. But thank you. About the junior doctors, is that the next one? Do you have to add on? Wishes?
It's difficult. I think that what we struggle with, because we are so busy doing the do every day, is kind of thanking the team, getting those messages out to them. So if there's anything that could be done around just making the team themselves feel in the right scope, we've absolutely had that. I don't know if it's still going to do, food brought to them, just as a thank you, which is in the really difficult times. But not even that, it's just maybe, it's mentions in the newsletter and things, and we'll make sure that we're sharing that with the team. I think it's those little things that just automatically pick me up the team, just to make sure that they know actually that what they're doing is really good. We can definitely do more about, 15,000, nearly 15,000 compliments, and are we sharing that as good as we can from the notes? So there's definitely some reflection on us as senior management, but if there was anything that anyone could think of, just with sharing the good stuff, because we do tend to focus a lot on the negatives and how we can make things better. Because actually, people just feel that they're doing a good job, they need to deal with it.
Elena, and then Debbie, and then we'll probably, Elena.
Thank you, Sarah, and thank you, Ruth. You really represent a group of heroes, and I'm speechless and very emotional, which is more what I found. And so thank you from the tip of my heart. You've mentioned a few times that because of the pressure, staff has to forgo training and does not have an opportunity to take breaks as they deserve and should take. I'm really worried about this, and actually our internal auditors emphasize the importance of the trainings in many, practically in each report we get at the audit committee, there is a mandatory training. So what can we do to ring-fence time for us, to ring-fence time for training, because that's the patient safety, that's also the morale for staff, to see the professional development and to have some breaks as normal human beings. Do we need to think about the reconfiguration of the department? The staffing members should be different. So I know that you can continue swimming upstream, but you probably need more team members to be successful. So what can we do in terms of practical things to ring fence very needed time for training and for breaks?
Ring fence time for training, we have yet to crack that. Every time we've had even mandatory training sessions, the nurses have all been. And it's a big problem there in the right hand, so you can't justify having staff and agencies when you have your team there. But the consequences are huge in terms of their skill and their happy. The way we are trying to tackle mandatory training at the moment is we're asking staff to do it in their own time, but if they prove that they've done it in their own time, then that time gets taken off their hours that they need to work. So they are work hours, but they aren't in a room at the same time. I don't know how this will work, but it's the way that we're trying to yes, I think we need more staff, particularly the doctors in terms of covering the weekends. That would mean that we may have more on weekdays, but we could get them doing things like quality improvement work, fellowship type work, and that will be coming in this weekend.
Debbie and then Palmer.
Thank you. Thank you for sharing your story. It's been all of you actually quite here. I think for those of us who were working also over the Christmas and New Year period, it was pressured, but you have absolutely brought it to life. So thank you for that. I also want to say I'm sorry. And I'm sorry because you've not had a good experience over that period of time. You haven't been able to provide the care and treatment that you would want to. So for that, I'm sorry. Equally, to you as well, those waiting times are not acceptable. And I think what's really important as a board is that we learn, and we go into next. However, we're not quite out of this yet. The thing that I also just wanted to mention was, it's really good to hear that you're having some social time. Can't emphasize how important that is as teams, to be able to have that time where it's just complete downtime, not part of work, that you can share as a team, because that moral injury, that feeling that you are not doing your best, you need to be able to share that as a team. So if there's anything that I can do or that the board can do to help you be able to have that, please do that. Thank you for all of it.
Okay, and
It was just really to say massive thank you, both from Heidi and myself, and the rest of the site team. Looking at Ruth from the heart, that was really useful hearing from the patient point of view. So thank you to both you, Sarah and Christina. Enormous thanks. Christina, you seem to be an ever-present member around urgent care. I'm not going to go home, but it is incredible. You can see that with the need and wider. Sarah and the team, you can see that from we have people knocking at the door to come here as consultants. So the way you treat your team, the way you look after them is incredible. I think when we were talking about this earlier, even though it was that bad during winter, I still would have brought my relative in over anywhere else. And that was the market. Even though walking through there, trying to see what we could do to help. You guys always calm, had a plan, go around, you knew where your sickest patients were, and that's all we could ask for. I think you did the job exemplary. So massive thank you.
okay. Thank you very much. I think the whole board would say thank you to you, but what you described is, because you talked about 5 years swimming a river, is really an acute version of a chronic problem. It's not funny, it's not unique, it's not strange, it's not even unpredictable. And when you've got 19 ambulances queuing outside your department, as you did on junior doctors and other things, people in the back of ambulances which are in the toilets, I think remind everybody, don't have wash facilities, none of those other things, whenever you take out. And you actually just think about the length of a 19 ambulance queue, which is quite a problem. It's just an unacceptable situation. So the fact that everybody was waiting, as you were 6-7 hours, and then arrive here in this ambulance queue. And of course, at the same time, everybody was in 9 ambulance through a queue. That's pretty much it for the ambulances that exist throughout the world. So thank yous matter, but we don't really get anywhere from the end of the day. Like banging on saucepans. It's all very nice, but so I think but from our point of view, there's two ways of thinking about this. There's what happened in here and what happens out there. And I think our responsibility, we started it, we told as much as we could tell your story into integrated care approach and pressed them very hard for an analysis and a detailed review of what happened. Because next Christmas is also going to be a 4-day bank holiday and then followed by a 3-day bank holiday. This is not unusual the way Christmas is followed on Saturday, Sundays, Monday, and Tuesdays. It's not rocket science. And we do know pretty much that if you graph attendances at EDs over the Christmas period, whilst the peaks and so on in the graph might vary, shape of the graph is identical every year. So it is a matter of what we do about this known problem. I think we have to find out how big an effect the arguably abnormal things of COVID into arguably, because every year is something that we can start to understand this. So we've asked for that, and but we also need plans here. We've talked about some things, and we're in the middle of planning that next year. And it seems to me that, you know, this is the time to make the arguments, make the case for what you need to provoke. Well, whatever else is asked for in the planning round, safe and secure urgent care system trumps everything. So I think now is the time to think very carefully through what we should be arguing for in the ICB, that's our problem. Also what we should be looking to support in the trust by way of what we can do, particularly those who have doctors over the weekend, whether they are SAS doctors or whatever, in order to carry the burden. Because the minute you start to fall behind, it's incredibly disheartening and difficult to dig yourself out. That happens every weekend. And if we don't do those plans and we don't clearly show that we've heard your pain, then you just dishonor the story. You might as well not spend 45 minutes. So I would ask you to, I would ask the execs to think very carefully about how they conclude what we're going to do in this planning round with a strong sense of priority on maintaining what we have rather than inventing clever new things, and making sure we have a safe and secure urgent care system in the hospital, and giving us good arguments to argue for whatever is needed outside the hospital, whether that is in the ambulances, whatever. And I'd ask you to think carefully, because if we will hear it, we will listen to what it would take to make this better for the people. But thank you very much for the time. Thank you very much for the story. It's very powerful. All three of you very powerful. And I would be more than disappointed if the board wasn't able to respond to you intelligently. No idea what the tools have to argue and your patients. Very much.
Thank you.
Right. Minutes of the meeting on 24th of November. We're happy to repair record. Yep, good. And the action law is complete or not yet due. I think you've got a short update to give us on urgent electric data quality. About the discussion, but you're probably doing that. Okay, thank you very much. Chair's report. I did mention that we have pressed at the Integrated Care Board. I mean, I've spoken to quite a few staff here and indicated about the ridiculous levels of demand and stress that is placed upon them over the Christmas period. It really doesn't matter how many senior clinicians you have at the front door, if there's absolutely nowhere to send the patients when you've decided, even when you're taking risks that you wouldn't prefer not to take. There's nowhere to send those patients. So we have pressed for an understanding and analysis of that way. On a different point, I have a note from the chair of the ICB looking for some changes in how we interface with the ICB, and in particular, non-execs attending from here, attending some of their committees, non-statutory committees. But in doing so, be placing the exec members in those committees and also providing full access to their committee packs, to same versions we have admin control, and in return having full access to our committee packs through admin control. I think this is a really difficult question about how best to do this, so I passed the relatively brief email suggestion from the chair of the ICB to Richard and to Debbie, and asked them to take it through the committee cycles. So you can comment on whether you think this is a good way. We might wish to suggest slight variations on it. So when you start to see that coming through the committee, please think very carefully about it before we go back to the ICB. And hopefully have a similar view to our friends in the NHS team. So that's all from me. Debbie.
I was going to focus on winter pressures, but clearly we've heard quite a lot about that this morning. What I will say is that there is something that happened prior to Christmas, and it is really called twindemic. And this really did contribute to our increase in activity in the NHS. And this is where we saw COVID and flu cases combined. And the acuity of patients was extremely high coming into our A&E departments, much more than it has been in previous years when we have had flu issues. We saw across the group extremely busy A&Es, as we just heard. From what we've heard this morning, that was no different for catering either, and the staff coped extremely well. We took the really difficult decision to postpone some patient appointments and some patient operations, and those decisions were not taken lightly in either hospital. It's not something that we would want to do, but we just did not have the capacity to care for every single patient who needed a bed. So for that reason, I'd just like to say to any patients who have had their operations or their outpatient appointments cancelled, postponed, paused, moved, I am truly sorry, but we are starting to see those patients being moved. At the same time, we also took a decision to reduce our visiting for relatives. And again, that wasn't a decision taken lightly. The numbers of patients in our organisations with both flu and COVID had increased substantially. And there was quite a risk that they were bringing in, when they were visiting their relatives, they were bringing in additional viruses. So again, we took the decision to reduce visiting. That's now back in place, and in fact has increased. I'll probably just reflect slightly on the two worst days, which were the 27th and 28th of December, when we declared critical incidents. NGH, I'm sure Carl will come on to it, but clearly been in a difficult place. Kettering escalated quite quickly just after Christmas. And we didn't have, across the group, the normal number of patients that we would have discharged prior to Christmas. We normally are able to reduce our bed occupancy in the acute hospitals at least to 60–70% prior to Christmas. And of course, we just did not see that this year. Patients were sick, they were sick at home. And the 27th and 28th of December were particularly challenging. And you heard from the team in A&E this morning, the numbers of ambulances that unfortunately we had to hold were excessive. I think what's really important here is that, as Palmer said, we did a lot of planning prior to winter. There was a huge amount of capacity and demand modelling, a huge amount of bed modelling. We knew that we had a gap in capacity, and system partners put plans in place that were to bridge that gap. What we thought for Christmas was our system partners, both NHST and social care, provide additional capacity. But that capacity that they provided was not done quickly enough. And that's what, when I say that we will need to learn going into next winter. How do we change our triggers with escalation? How do we become more sensitive to the pressures so that we are not reacting, we are being much more proactive? And actually, when I say we, I'm talking system, not the accused. That's really easy to say, actually, but it's quite difficult to do. The amount of meetings, the amount of number of discussions that we had over the Christmas period with systems to try and get the additional capacity in and spread the risk evenly. As you've heard, we had expectations for our ward. That was exactly the same in Kettering also. Yet we didn't see some of that risk being taken in the same way across the whole system. And again, that's something that we must learn from as we go into the next one. I think the other area just to note really is the next couple of months are going to be really tied up with operational planning as we move into the next financial year. This is quite a large piece of work, very tight deadlines. We'll come on to talk a little bit more about that in part two today. But we have started to see some inroads with our productivity across the group. So the theatres work, the ICANN work, we will clearly need to do more of that as we progress. There are three key tasks for systems in this year's operational planning. First one is to recover core services with productivity. And as two organisations, as part of the group, we have done really well actually to hold our waiting lists, albeit they are growing, to not have the same pressures with our elective care that other organisations have had. But there's more to do with our productivity in that respect. The second key task is to make progress in delivering the NHS long-term plan. And then the third one is to continue transforming so that the NHS is fit for the future. So I think we'll clearly talk more about planning, but what is really clear as we go into the next financial year is that we will need to continue to provide safe services with that expectation from the public that we are providing gold standard service, but with less means to do so. So I will stop there. One thing I would just like to say is thank you to everybody who has been involved over the winter period with this incident, especially Palmer, who has been on most conference calls, worked tirelessly. And thank you to everybody.
Thank you.
Just pull out some of the key highlights from Heidi's report as the Hospital Chief Exec. So you'll know we've had quite a bit of industrial action across the patch. We've had high patient numbers, high patient acuity, and then crucially high patient dependency, all causing a lot of staff stress, and what I'm going to be even talking about this morning from some of the staff stories. However, there has been some very good system working. We have made enormous inroads. We'll cover that in the IGL. Internal flow plans have come to fruition. Wellbeing support from our people departments have been excellent and constant throughout the Christmas break. Team cohesion, be that what you've heard this morning, indeed wider on the wards. And also, you've seen those who are now walking past the front door, we now have a new streaming hub to make sure our patients are not waiting in the cold. They also have enhanced streaming with more rooms to be able to do observations and such like, so we can stream to their locations quicker. So, and we continue to work with our external partners, the emergency care and intensive support team. Regularly, they come in, I mentioned today, meeting myself and Heidi, who do give us an external point of view on how we're doing and make sure we are benchmarking ourselves, putting ourselves in context with everything we do. Wider, looking at the quality side, we have all of our Don Fellows been presenting in the last 2 months. Shared decision-making councils coming to fruition, pathways to excellent flourishes, with more wards getting blue accreditation. And Christine Amanda mentioned one of her wards getting blue this morning, and it does go a long way. They put a lot of effort, those who haven't seen it, into getting those blue awards. So for those teams, it is a real achievement. Our cancer continues to grow. We only have 126 on our legacy. I say only, that is disappointing, but that nationally does put us in a very good position. We continue to lead nationally on some of our 28-day faster diagnosis, and indeed the gynae team are presenting nationally as consistently they are the best performing every single month throughout the entire year. Usually my screen has just turned off, so I've now got my notes. There we go, it's back on, apologies. And we lead our RT team in terms of we have 380 patients for 80 weeks. That's not good, we don't want that to happen, but when you put it into context nationally, we are one of the best regionally as a system, and indeed leading nationally. And lastly, we've had a CQC visit to maternity recently. We do have the draft report, more will be coming out once it's officially published. But just to thank the maternity team for all their efforts during that. Actually, what they've done over the last year, maternity is nothing short of incredible to turn around the service, turn around the vacancies and everything else. Real credit to how the new leadership's in there. So.
Okay, thank you very much. Any comments or questions on any of that? Yes, Joe.
Thank you, Chair. I just wanted to re-ask my earlier question. Have we done enough to thank our staff? And I know, Chair, you said that could be a bit empty if we didn't follow it up with actions. But last year we offered staff vouchers for events and so on as through the Northamptonshire charities. Now, I don't know how well that worked actually when they took it up, or whether there's something different we can do, or whether we've done enough, because it was mentioned that staff do read on the newsletters and so they do pick up thanks from there. So not being as close to the floor as my executive colleagues, I don't know if we've done enough or not.
Any other comments?
Thank you. Thank you, Palmer, and to all the team who's doing really incredible work to keep doors open and helping patients. My question is about the CQC inspection. I appreciate that it was for the particular service, but I'm sure that there will be some advice applicable to many other departments. So if you can elaborate a little bit about the learnings, if there is any program of sharing learnings when there are external auditors, external regulators coming to the particular department, but learning is utilized across the whole trust.
Absolutely. So I think if I start with the first one, thank you, staff. We are working with the charity to do something in February, hopefully. I was just trying to work out how we do it for all staff to make sure everyone gets a thank you across the board. So more will become, and we talked about it with some of the staff to make sure it kind of would land well. So there are some plans around. So coming on to the CQC report, I think the actual report itself is still embargoed, it hasn't been published, so I can't talk about the learning from that one yet. But we do regularly look at other CQC reports ahead of time. So we look at the hospitals that are like us, near us. We look at the learning from there, where they're focusing. But really, it comes into making sure our assurance process is in place throughout. So when you look at our divisional assurance meetings, we are doing them according to the CQC domains, looking through them and the data that we're closing through them. And indeed, we look at where other trusts have fallen foul, or ourselves, or likewise, we'll be passing our learning from the maternity side, pediatrics, etc. So we do it across the group, regionally, nationally. I think the team are quite good at picking up. I think obviously we have Heidi, who is next CQC chief herself, so I think it's really useful having that. So we do put a lot of emphasis on that, not just because it's a CQC and it's an inspection, but actually that is a vehicle to having better quality, better experience, better staff.
Yeah, across many
exactly.
disciplines. Yeah, that's what I was saying. Thank you.
Okay. Anything else? No. On the CQC thing, I'll just remind you that we commissioned ACLA consultancy to help us with the well-led session on the 17th. Engaged in morning and engaged in afternoon on well-led preparations. I should think about CQC well-led, which fits with all the other stuff. And the best way to think about the CQC inspection is not with terror, but with a sense that it's the best pre-consultancy you get. Even when they're wrong, they're right. It's the other thing to get it right. It is a pre-consultancy in the sense that they come in and tell you things. So maybe most of you should know, but see those things. Okay, thank you very much. Palmer, board committee summary is IGR report. You can be Heidi again next 40 minutes or so.
So I will channel my inner Alan and ask chairs of committees to be brief on their points. So I'll just hand over first to the Group Transformation Committee.
If you don't mind, I'm going to start with finance and then do transformation. Is that okay?
Yeah, so again,
So we had our first, well, not our first, but our relaunch committee in common for finance, which was fast, furious, busy, packed 2 hours. But actually we covered everything that we were meant to cover. And I think pretty much everyone managed to take that step up and talk slightly differently around what was going on. So that was good to note. Just some comments on performance. We've had some really good work done by Mama and your team. I'd like to say thank you for that. Electives are running at 122% of their growth. Improvement in theatre utilisation with weekly theatre transformation meetings taking place. And there's probably a number of other areas in the IGR reads pretty well. So, thank you. Main concern that was noted at the board is around the provision of diagnostic MRI capacity, which will inevitably restrict our ability to carry on those good performances moving forward. But so I do need to make the board aware of that. There are short-term options, but nothing I think that really stretches into next year. The second point to be raised is around the increasing disconnect between financial planning and operational performance. We've touched on it this morning. Based on planning guidance, delivering elective care is going to be more challenging than ever next year. And we need to be aware of this disconnect and what our financial targets are saying and what we're able to deliver to, I think, are going to be very difficult to bring together. And this is where the transformation work becomes increasingly important to address this. We'll come on to that in a minute. Financially, we're in a difficult place. I think John would agree with that. With enhanced oversight controls placed on us for workforce management and pay, essentially to review and approve all recruitment staffing positions. We have a deficit, a year-to-date deficit of 11 million, 9.3 million plan. Under delivery of efficiencies really driving this, plus the required expenditure savings expected in the annual, the updated annual plan. We're actively working though with the divisions to increase the scale and pace of change on agency reduction. But you've heard this morning how difficult that is for the departments. Anything to add, John?
A couple of things if I can.
Yeah,
Rachel.
sure.
So just to put a bit of colour on those numbers. So we are reported to the committee in terms of workforce, and this is the financial challenge is predominantly a workforce issue. You heard from our colleagues about the increases we've added to our workforce in response to the unrelenting operational pressures. December was not an outlier. I mean, we had in December the highest number of substantive workforce in this hospital ever. And it was one of the highest overall workforce ever. And we saw an uptick in spend in December in response to the critical incident. That's entirely to be expected. But clearly we've got some work to do to kind of unpick that. I very rarely refer to divisional performance at the board, but it's relevant in terms of how we take this moving forward. So we've got a variance to plan overall the hospital of about £9 million, as Rachel's referred to. Eight of that 9 million sits within medicine. And I think that explains one, where we need to have targeted support and kind of concentration, and it bears out those significant challenges that we've had internally and system-wide in responding to those urgent care pressures. So I think it's really, really important that we focus on that. On non-pay, part of the reason, again, we're running that £11 million deficit. Significant pressures around inflation, around clinical supplies, and around utilities, far in excess of national planning or national funding assumptions. And you know, we're seeing in the national media that that's expected to drop. I will remind colleagues that when people say the increase in inflation is dropping, it's because we've had a 10 to 12% increase, so prices will be 10 to 12% up, and then another 5 on top of that, so 15, 16, 17% on top of where they were only a year ago. That isn't a good news story for the money. It means it gets more pressured, albeit the steep climb is not quite as bad. We clearly need to work through that. And just to kind of refer to some of the detail, our non-pay variance looks like it's not a problem, but the reason for that is we haven't spent as much money as we had budgeted or planned to do around elective recovery. So we've got those quite significant inflationary pressures are being masked by a lower than planned spend in that area. And that's really because we've stepped up our internal work and made best use of our capacity internally in delivering what is still standout performance across Blanket.
Thank you. Anything?
Yep. So it's just worth highlighting some of the context how we've been to this one on the urgent care side. So you've been presented how hard it was and how bad everything became. But it's also interesting when you look at it since when I arrived last year and presented to the board where we are with pathways, where we are with discharge, where we need to get to. We weren't in the best places. We're a national outlier for the number of people over 21 days. Regionally, we are the only system to have moved the number of 21-day plus in the right direction. So we've gone from having only 200 patients under 7 days here, out of 589, to now having over 300. So we're over 50% of the patients under 7 days. That's an enormous shift. Going from over 200 over 21 days down to 130. Number of discharges from our supported aspects, November went from just under 200 to in December 276. So it's another 30%, over 30% increase. And that additionally also knocks onto our pathway zeros. When you look at our number of people waiting for pathways, they were tipping out at almost in the high hundreds. They now dropped to 30%. So now under 100 waiting on the pathway at this moment. So enormous amounts of work been done. Where does that come from? 2 days, I think, length of stay has been done by improvement internally, which is huge, considering where we are. 10 days has been dropped by the system. An enormous drop in length of stay. So we've almost achieved a 2-week length of stay drop for those who are going on supported pathways. And the data looking back in the system, the emergency care support, have looked back at everything over the last few years. The critical incidents we've declared the previous Christmases, Januaries, and that kind of thing, it took us 6 to 8 weeks to recover from. This one we've just had took us 11 days. So the teams have done incredible work. I think what's interesting is whilst the system could have stepped up more in January, some of them we knew wouldn't get here until January because the plans and improvements weren't lapped. For example, being able to open up our specialist care centre beds to 452 beds. That required improvement. Which started back in September time. We planned for this back in October. We had our first meeting for next winter this week already as part of the ICANN network and how we work through. So I think there's huge amounts of change. We are moving in the right direction. And also what's really crucial is when we already covered, we're doing all that whilst also maintaining our cancer position, whilst also maintaining our legacy position, whilst also making sure our turnover decreases. And everything else. So when you look at all these metrics across the board, I think one of the key things I think was asked was bring out in our GR this: how do we know we were safe during all this? These are all numbers, but we've had the favour of the people side. So when you look at it, the data exists with the same amount of reporting, we didn't dip, we didn't go up. So there are people are still reporting over that period of the last 3 months. Our falls have not got worse. Our pressure ulcers have not got worse. So don't get me wrong, we want to go through the right direction. If we can't expect it 2,500 more people over a 3-month period, you might expect it to get worse. Actually, we maintain the position. So in other words, I would say we look better. We look at our mortality data quite often to make sure there isn't that constant harm going throughout, and that might play out in the community. But in terms of where we look at it in ED, where it presents itself, I was assured that we are safe where someone presents with a high acuity. So if you come in with a stroke or anything like that, or you score highly, you are seen very quickly by the streaming hub and you are pulled forward in that queue, even if there are 140 people in that department. People like Sarah, Christina are all brilliant. Where we become undone, like they were talking about, is that long length of stay. Are we safe there? The majority of the answer is yes. We do things differently here. We have medics at the front door. We have 3 medical consultants every single day in ED giving medical care. So your pathway does not stop. So it doesn't mean that we might not cause harm on an ongoing period. But I think as a trust, we've done everything we can to make sure people are safe. As a system, there's everything we can do.
Thank you.
Sorry, I didn't respond to your comment about MRI that we discussed at the committee,
No, that's
Rachel. So just to confirm to the board that we have considered the risk, benefit and cost of keeping capacity on this site until the end of the financial year. We have agreed to support that investment. I'll let Palmer talk about the impact of performance. I think it means we'll have no 13, is it 13?
Yeah, no waiting for 13 weeks for MRI by March. It seems to get better. And reduce already our cancer vision rates to 40 sorry, miles in the right direction.
Thank you, Rachel. From IGR, I can see that there is for the concern of variation in 13 KPIs for our hospital, and 7 of them attributed to the performance, so the finance and performance committee. During your sessions, did you have an opportunity to drill into it and really challenge management? I'm particularly interested in 2 KPIs, unappointment outpatient KPI, which shows over 20,000 people, and size of RTT waiting list of 36,000 people. So we're doing brilliantly to keep and react to the emergency needs, but it feels that we are kind of living a big battle on the left side.
Yeah. So
About
yeah, absolutely. We do go through that regularly, and it's for assurance, it goes through our elective assurance board, and we do monitor this, both the size of the PCL, the long waits, and length of time to first appointment. You see from our the follow-up what you've quite rightly raised, we did talk about it. It was one of the papers that came separately to the committee, and for assurance, there will always be an amount because you've got people coming to the front door. Over December, it went the wrong way. We expected to because we had more bank holidays and we knew we'd have to pull more staff off for industrial action and things like that. However, you can already see in January, which was an incredible increase in activity that's then got back into that, and we are seeing a drop already. So we kind of knew there would be a blip, but it's already been done. So it's
Thank you.
Just moving on briefly to transformation, because I know we've got a paper on it at the board. As mentioned earlier, we don't just have an opportunity to get this moving, but we have a requirement to get this moving. And I think I can't emphasise that enough. There's a couple of items on the agenda. The first two being a desire on the part of the committee to be able to clearly see the priorities we've got. We've got to be able to attribute money to those and understand exactly how much either we're benefiting in some way and where that money is going. We've got to be able to track that. We've had concerns about delivery, and the group has asked to see the priorities in a lot more detail going forward. The last point was around state transformation delivery. Yes, we've done a huge amount of work. Stuart Paul's been fantastic. We've got a lot more to do, as you know, and I think we've got, we're going to have some difficulties, I think, some challenging conversations next year in terms of what we spend on money. But state transformation is moving pace. That's it. I'll leave it to Becky to really present them.
moving on then to audit.
Thank you, Palmer. Audit committee got a reasonable assurance from our internal auditors and local counter fraud specialists. They're progressing well according to the plans, and there is no outstanding actions with the high priority one, which is a good place to be. And the committee is also pleased with the reasonable assurance over the progress of risk management strategy implementation. That's basically the main highlights, and we will have our standing financial instruction notification later on our agenda.
Can I just say, from an audit committee point of view, we agreed at the audit committee that we would be presenting or producing the accounts on a going concern basis, and we reviewed that. It's not anywhere near as challenging as it has been in the past, but we reviewed the guidance. Guidance hasn't changed from the past year, and therefore the plan is to produce accounts on the basis of going concern.
Thank you, Palmer. Digital committee. I think committee would like the board to be aware about very limited assurance over the digital roadmap progress, and that will be addressed through the planning how committee works and the planning within Natasha's department going forward. And in terms of decision made, committee has approved the potential extension of System 1 across the hospital. Natasha, you wanted anything?
Maybe a point just to raise, particularly as we are in NGH at the moment, that the EPR tender has also gone out for procurement. And I will re-emphasise the point that you made earlier around the real need to reinvigorate the Group Digital Hospital Committee, but that's in line with the refocus of priorities that we need to do. And we have seen a drop in attendance and engagement with the committee, which I would suggest is probably in line with the fact that it's felt that we've become adrift from what our organisational priorities are. So there's going to be a big focus on that re-engagement and reinvigoration.
Thank you very much. People, please.
Yes, thank you. So we received assurance as a committee of the areas on the report here around the detailed analysis of formal employee relations cases, which show a reduction in cases and give us some insight in terms of the length of cases. This is an issue that we've had for some time, and it's the first time that we've had what we considered as a committee to be a full report that started to give us assurance. There's still work to be done there, but we were assured by the fact that we received the report, and we now feel that we know where we're at with that. We noted more progress on supporting clinical collaboration. The DBS requirement has been aligned across the hospitals. There have been more joint policies agreed, and there's been support for cardiology. And we also received assurance in terms of the work undertaken at both trusts to manage the impact of staff strike and ambulance strike days. There were a number of areas as a result of the discussions that we agreed to pull forward to focus on our people strategy days that will be in April. One of which refers back to the staff story really around support for mental health for staff, obviously given the impact on staff well-being, so we want to have a real review of that and get a deep dive into support for mental health, workforce planning, which is obviously key. It feels from the discussions that we're having across the committees that we've got this refers to it as a triangle. We've got money, we've got people, we're performing really well in some areas, but is that, you know, we've got more people doing it, so is that why we're performing well, and where does the money fit in? So I think that the workforce planning is a really important piece of that as we move forward. And resourcing in general, given the focus on reducing the use of agencies, so that clearly has come into our workforce planning. As a committee, we made 2 key decisions around our KPIs. We firstly agreed to a reduction of our KPIs. We've got 27. Looking at those in detail, a number of them were duplicative and really didn't actually give us information that we needed to be focused on. So they've been reduced from 27 to 15, and the KPIs are now very directly aligned to the people delivering the plan priorities. And we have also finally agreed to align the 3 people KPIs that we're not aligned. So we have been operating with across the grid with different sickness, turnover and vacancy targets at both hospitals. So they were being reported through to the hospital, but it was to the joint people committee, but it was different for each hospital. So we agreed proposed new targets that will obviously make a lot of sense dealing with a group of people committee. In terms of the 2 areas on our report here for assurance levels, people performance report, we are still the key areas that we've got there. We are still below target on appraisal completion rates. We're still in the period under review. Our sickness and absence rates were running almost double the target, and we were over on our vacancy rates. Turnover was coming down, so turnover was below target in the period overall. But I think given the figures at this stage, we can only give limited assurance on those to the board. Within that, one of the things that I do think, and Jill, I think you raised this a bit earlier, we still at this hospital here need to do more work in terms of trying to recruit. There is a lot of work that's gone on, and I do acknowledge that, but we're not where we need to be, and we need to be a lot smarter in that. We need to be, particularly as the turnover is slower, we need to be quicker when they've told us they want to come and work with us. And the safe staffing report, at this stage, again, I can only put limited assurance in on that. We have an issue with the data. So this has been flagged up on a number of occasions where the data that we're looking at, when we question it, it is acknowledged that the data is accurate. So we can't, as a committee, provide assurance on that until we've got the assurance that the data is accurate. My understanding is that there's been work going on in that area. I'll pass over to Paula in a second. The last thing that I did want to just flag up, and this is just on the back of some of the information that we have there. This month we have regarding the safe working report. There were 2 things I think that are worthy of note. Firstly, we didn't get the NGH report in time for it to be considered by the committee. So we've not been able to review the NGH report. It literally arrived at 8 o'clock the evening before, and I felt as chair that it wasn't absolutely so that wasn't conceived. However, what we saw in the KGH report was, although there was a reduction in exceptions overall, there is a significant increase in exception reporting by FY1 doctors. And so this feels like if you kind of triangulate that with the comment about the junior doctors and how we're losing them, this feels like an emergent risk.
No, just around the time to hire issue, absolutely. And we have first we've got some additional resources recruitment at the moment, so we'll see some improvements coming through. And we've also agreed with that team around some additional transformation work as part of the processes there. And there is definitely some learning that we can do from catering positive impacts as well. And I completely agree with Denise about the junior doctors issue. And things that we need to have greater scrutiny on. Just in terms of the KPIs, we should formally note, I think the recommendation to the board is to align our KPIs for sickness at 5%, for turnover at 8.5%,
Just ask a quick question. So Denise, when you say staffing, the committee is going to receive a midwifery award workforce plan in March. Can I just check this also covers medical staff, neonatal nursing and medical staff as well?
So the first one, the maternity workforce plan is being led by our nursing clinics in conjunction with the team, and I would expect it to be an overarching plan that would encompass all staff.
Paul, can I just check you, are you asking the board to approve that recommendation?
Yep, so I think you're looking at me on so group quality. Okay.
We had a reboot of the quality committee in common last Friday. I think it was a positive experience. I think it was helped by several things. One is that the timing of the meeting is now later in the month, so it allows a better flow of data. And there was a very useful pre-meeting before the meeting to iron out exactly what we're going to be discussing at the meeting. And also, we're now writing in a sensible planning meeting well ahead of time as to what should be included in the discussion and what is needed to be included in the discussion. And I think it was very excellent convenership on a day by Chris. Very packed agenda, 2.5 hours, 2.5 hours of work. So we went through everything. So I think it's good. We have discovered some differences between the two trusts in terms of the content of the discussion. The action log from NGH is still way too long because there's a lot of open, unclosed items that need to be closed off. I think that comes on the board a bit as well. From the IGR perspective, there are obviously some apples and oranges, so some harmonization needs to be done in order to facilitate direct comparison on relevant topics. What was highlighted is very useful discussion and appropriate focus on the exception reporting. So I think that these are items that's particularly relevant to staff. So I think we spend appropriate time on these. You've got the report on the highlights in detail. So I think the discussion and decision was that we would have the same report across the group and probably highlight the things that are relevant to the individual site at the individual board. So we have heard about the diagnostics problem, which is remaining an issue with a high demand on MRI scans. And the business cases submitted to the board to NHSE has been rejected. So we felt that this is not giving us any steer to go beyond limited assurance at this stage. So this is what we need to continue to press on. In terms of the critical incident, we know between the end of the year to the beginning of the year, there's a lot of work that we've done. We've heard a lot about the repair and also additional beds open at both sites. And it did handle very well. And the important lessons we flagged out need to be put into our corporate memory for planning for the next year, which I'm sure will have another pressure with another winter. But we've also gone back down to over 2, so we congratulate the whole team about that. That's potential assurance on this aspect. Maternity safety and CNSD, we approved the KGH CNSD mission at the time of committee, but the papers were not ready to be approved. So after that, as we had a QA meeting following the committee and a revised submission, which I took chair's action to approve the submission with the status that 2 out of 10 were fully compliant and 8 remain partially compliant. I believe that has been signed off for the submission. It was submitted yesterday. So that aspect. NGH, we continue to celebrate and very happy about our shimmy numbers. There is still continuing a weekday weekend gap, which we're trying to understand. KGH, there's a bigger issue there, which they're also working on. But we have good assurance from the NGH side. Finally, the items related to KGH children and young people in the program. There was a CQC unannounced inspection in December. The committee was assured that action had been taken, but no, this is a work in progress. So there's a reasonable assurance and the committee for to note. Anything else, Jill or Richard to add?
So just to correct on just one since happened since that board, the CDC has been approved. So we do have a case now going through for a local GP surgery off the top of my head. So we will have more going in locally. And like John said that earlier, we've approved MRI on smart until 31st of March. We also then can draw down separate funds going into next year. So the MRI risk that myself and Faye presented at both committees, I think can be closed. But I just wondered, just more questions. If Helen hasn't been through.
I've got nothing to add.
Well, thank you. I think just briefly, as Andreas said, despite the acute pressures in ED in December, we have put some extra measures with spot audits around vital packs and pain sports, etc. We haven't seen any increased harms or incidents coming through particular urgent care. In terms of the IGR, I completely agree that the certain metrics are not compared or measured in a proper way in terms of similarity. And I think we still have to work on that so that at least the most important of the key element of the joint meeting will be to learn from each other. But unless we have a standardization of the data reporting, that won't happen. So that's my only comments. Thank you.
Thank you, Palmer. I appreciate that there was no substantial increase in serious incidents related to pressure ulcers or others and medication errors when we compare on month-to-month period. But when I'm looking at IGR on 12 months period, I really see that in January 2022 at NGH, all these three KPIs have really become rocket high. So did we do the analysis? Why have we moved to the basically new plateau, which is not a good place to be? And what can we do to bring it down?
In terms of medication errors, what has happened is we have rolled out a ward-based pharmacy project and extended to different areas. And that is one of the reasons where we are seeing increased reporting, increased pickup, but that doesn't extrapolate into harms. So that's why we have seen that we are constantly monitoring that through our subcommittees of the medicine and safety group. So that's point one.
So we were not addressing it to that level of details prior to January 2022.
So the ward-based pharmacy project is been extensively rolled out. That's why we are detecting and reporting it is increased. That's the point why we are seeing that extra metrics in the medication errors in particular. But prior to that, we didn't have a ward-based pharmacy project. So the reporting and was not that robust. So that's the reason for that. The second point was around pressure ulcers.
It's called serious or moderate harm, pressure ulcers, and also just serious and moderate harms. So
from the harms point of view, yes, I think that's something which we have seen nationally because of the high acuity which we have seen in the last 1 year. For example, summer we felt like winter here. So that's the reason I think we are seeing more harms coming through. But the most important, I think it's a good marker. If people are reporting the data and we are detecting it, I think it is a good marker for measuring of safety. But I get to a point that it has increased over years, particularly even the serious incidents when we had 70, this year we had 90, but that reflects the activity and particularly around the cancers as well. There have been a lot of incidences we have seen around cancers. So that's something which we know, but it's down to the acuity as I mentioned, as compared to year-on-year increase. In terms of pressure ulcers,
I'm happy to take that. So you're absolutely right. We did have a spike in the number of patients that were damaged by pressure in December. There were a number of contributing factors to that, hypoxia being one of them, and we had a lot of patients through. that had respiratory diseases and required oxygenation. We have to also bring in the fact that patients spent long periods of time in ED, SAT, and also in terms of staffing levels and opening escalation areas. So a lot of work has been going into that. We also track back every damage that we do track back to the length of time that somebody spent in the ED to see if that indeed has been a contributing factor. So I'm waiting to see the January data, which is being produced at the moment, and to see if the interventions that we're putting in place will have an effect. I'm hoping to see a drop down. There were a couple of patients that we particularly going to do some focused work on, and that we're going to look at their whole journey within the organisation and see what organisational learning there is to address the issue. Thank you.
Just one issue, just for you to approve the committee in common continues. I think we've only approved the board one that we've had. We need to go 2 more to match catering. It's different. Okay, I'll get back. And the last bit, just from the Isaac point of view, just to congratulate him on being made permanent MD. It's made a huge difference already. So congratulations.
Okay, thank you very much. Anything else around any of that? No. Okay, thank you very much. We'll get a break back in 10 minutes, please, 10:45.
Yeah.
Okay, thank you very much. Coming back on time, more or less. Review of a dedicated to excellence, but Becky, please.
Thanks, Chair. So this is as part of looking at a selection process, part of the planning process to look back at what we've achieved collectively in terms of the dedicated to excellence strategy. This is the first time we're looking at it, but I know Karen did a session at the board development session, when that was 2 weeks ago. And what we set up, Karen has set up in March sometime with committee chairs to have a look at the detailed breakdown of all the metrics and delivery, as well as sometimes also committee agendas, hopefully, so that we can have a full review of what are the different things we said we do in each of the areas, how far have we got, and particularly what does that mean in terms of the metrics and ambition. So, but really wanted to put together a paper that highlights, as part of within transformation, we have the strategic portfolio office that keeps track of the achievements we've made across the group. So really wanted to highlight what some of those things are. It's actually really lovely putting together this paper. I think sometimes we forget all of the things that we have been able to do, and rightly spend a lot of time on some of the challenges. But it's really heartwarming to see some of the things we have been able to achieve. So we launched the strategy in July 2021, and I was saying yesterday among much fanfare with the launch, and it outlined our strategies, the vision, the mission, our values, our strategic priorities, our 5 strategic priorities, the clinical strategy, and then the 7 enabling strategies. And we have done a number of things in each of these different areas. So starting to embed what those values look like, starting to celebrate some of the achievements and encouraging that innovation and improvement that we want our staff to focus on. I won't go into all of the detail because hopefully people have had a chance to have a look, but across each of our strategic priorities, we've had a number of different recognitions from national and regional awards, everything from patient and public involvement in our community stroke service, HSJ awards for some of the work on deteriorating patients. We've been hearing from Palmer this morning some of the fantastic work on the kind of operational work that fits within this partnership, some really good steps in our green agenda from a state perspective, and lots of work looking at how do we better support our staff through induction processes. We've got some new management and leadership training in place, and obviously all of the health and wellbeing work that Paula's team focus on. We've had further development on the clinical strategy, and we had the 2nd Cardiology Centre of Excellence in January conference. We've also had the Cancer Centre of Excellence conference, and obviously we've had the new robot to support that, which was fantastic to hear. I think it's November board, wasn't it, that we had a visit from the surgical robot team. And then each of the enabling strategies have started to make inroads in some of those improvements for our group, whether that's over 2,500 submissions by patients directly to their clinicians for some of their outpatient care through Isla Care, whether that is looking at some of the fantastic Pathway to Excellence work that's held here when we had the Pathway to Excellence conference, as well as all sorts of other events actually with the Don Fellows, haven't we, here in NGH, part of a successful bid for becoming part of the Leicester Biomedical Research Centre, so £36 million to really increase in enhanced access for our patients to trials, bits of new build critical care centre, and Karen's been instrumental in participating in our integrated care system strategy. So I've just pulled out a few things there, but really wanted to highlight some of the things that we have done. Having said that, we've heard this morning, haven't we, how challenging the context that we're working in is. So there are some areas we haven't made as much progress as we perhaps would have hoped. But what we will be doing through upcoming committee sessions is looking at each of those detailed metrics. Where were we when we set out the strategy? Where are we now? What are the things we said we do? And what progress have we made to deliver that, and where we haven't made that progress, why, so that it can help us inform the priorities, strategic priorities for next year.
Okay, thank you. Comments, Rachel?
Thank you, Becky. I think I've got a couple of comments actually on this. I think firstly, my concern is that a number of these things were happening anyway. So are these all under your transformation team? They're not?
No.
Okay. I think secondly is the lack of numbers paper. Are we able to have oversight somewhere of what each of these initiatives and transformation initiatives is doing in terms of affecting the numbers?
Yeah, so that'll be the work that's going through the committees in February. There's sessions booked for each of the priorities with committee chairs first, and then a session on the committees to have a look at exactly that, to detail the metrics. Get Karen will be leading.
Yes, so Rachel, this is around looking at the group priorities and progress against the group priorities so that we can inform our priorities going into the planning round for next year. So that's the piece of work that's. So what we're going to be doing those priorities, and are those priorities still valid if you talk about the full training session, and what we'll be prioritising given the national requirements for the coming year?
I think my concern is we did this time last year and we pulled together a list of transformation initiatives, and actually some of them haven't happened this year, and that's caused our problems with our accounts. So actually, how confident are you that you can deliver this?
So I think that's the work that we're going through the planning round at the moment. So this set of paper, it is around our collective achievements as a board.
Okay, yeah, but next year.
Yes. So what we need to do is say, partly through the paper that we took through transformation committee, to say these are the 4 pieces of work that my team will be supporting, and through the planning round, what are we expecting the impact to be on each of the different metrics? That work is underway at the moment, and then it will come back round through the committee cycle.
Yeah.
It's just a threat for this next year. I think there's ever been such an importance we've put on transformation and quality improvement and dedicated to excellence. Because we have people who are absolutely amazingly in this hospital. It's not often you find that across the board. If you look at, as John highlighted earlier, in medicine with 8 of the 9 million pound overspend sat in it, actually they're the one division who has driven down their turnover from a back rolling target. So they actually want to go in the right direction. What we have and what we're lacking in is the tools to enable and the timing as well. And we're talking about training and everything else. So I think with Becky's team moving forward next year is understanding how we lead that, how we take apart services, how we look at pathways, how we transfer care from consultants, nurses to AHPs. All the bits that enable us to do things differently whilst not only not increasing the size of the first work, but decreasing. So yeah, it's just that level of focus has to be on this, how we enable those divisions and the front lines, enable our changes.
I mean, what harms basically? I think that we have, it feels we have an issue with the digital side of things. There were a number of items with limited assurance from the digital committee, and a lot of that is absolutely essential to get these things in place to enable all of the others. So that has to be a major focus. And then the exercise of almost taking things apart, listening to the people on the ground, really on the ground, and how is it going to work better? How can things be better? How can things be organised better? If that really needs to be the focus on unblocking some of the things and helping some of the stuff that we know. There's dreadful stories on this morning, and that really has to be the focus. It's ownership of that, isn't it? Who owns this? Because it can't just be seen as something that's owned by a department over here. It's got to be owned online.
So in John's report shortly, we'll be talking about the financial challenges and the things that we're doing to support that. John and I have both been heavily involved in the week of vacancy control.
now have with our staff. And it's really interesting that staff come along, their level of understanding around the workforce and the workforce controls isn't where it needs to be. It's getting there, and we actually in NGH in particular, we've seen a really good progress with vulnerable staff in particular, and it's really got to its fill. But what is really apparent is that coming along to those panels and trying to work out how you can address one particular vacancy is not going to solve this. And actually what we need is support on the ground in divisions to help people look at their services. And certainly Becky's team, the new QI colleagues that have been division based, I think that's really helpful in helping people to look differently at their workforce. That's the only way we're going to address this bigger.
Thank you. Just a couple of points. I think the first one is you're absolutely right, Palmer. We will have to really gather pace and transformation. But we do need to be clear as two organisations and a system that it's transformation with cost, because we just can't afford what we currently have. In terms of the priorities, Rachel, I think what you're asking for, and we will do, is at the next board meeting, provide an update against each of these as to where we started in terms of measures and metrics, and where we currently are, and then what does the future look like in terms of the numbers that you can get into the actual key. I think it's probably fair to say that with these priorities, they were ambitious. As we move forward in the context that we're currently working in, we will still need to be ambitious, but we do need to have some realism. We do need to be realistic. There is less money, staff still heard and very burnt out, so that should be realistic and what we can achieve over the next 1 to 4 years.
Thanks. I think Debbie has covered what I wanted to cover. One is about a realistic expectation of what we can achieve with clinical input, with so much of high acuity. That's point one. Point two is, I think what we are seeing is a lot of strategies are not interlinked. A lot of transformation priorities should be linked with quality metrics and what we need to achieve. For example, in medication errors, we talked about it, but our EPM has fallen behind. That's one of the biggest transformation risks which we are carrying here. So I think linking prioritization to quality and safety is very imperative, considering the limited resources we have in the transformation team and also the financial resources team.
Thanks, Chair. Just coming back to Denise's point around digital, of course, my ears are prick up at that. And to chime in with your point around digital can be an enabler for some of the transformation you've talked about, just to provide some assurance that the wider planning and prioritisation process that's going on with Becky, Karen and others will include digital impact. So digital isn't isolated in some of that prioritisation, which I think has led to the lack of assurance and at the committee that we're focused in the right areas. But yet we have to balance the tensions of we haven't got the money to invest and making sure that we are realistic about what we set our sights on as well.
Something really good about that's really good to hear. We do need that assurance, I guess. One of the points that I was trying to make is, are we in all of that? My concern is that everything's dealt with in departments up here, and we need to be, we need to be talking to the people that are there at the front door every day trying to deal with this, to see what they need, because their needs in some cases are cheap and quick and easy, but we don't get to hear them because it's all here, and I don't think we do enough of that. So it's great to hear the triangulation there, but we just got to make sure that we're really getting those skills.
I'm going to be uncharacteristically positive. That's okay, Chair. So we've just had an outline business case approved for £20 million worth of investment in the new EPR at this hospital, and with lots of revenue associated with it, and a massive opportunity to do the work that you just described there. And as part of the plan, a lot of engagement work and a lot of resource being allocated to make that work. The important thing that we need to make sure is on that, and I think we've referred to the CDC investment, that we've now had confirmation of funding for as well is huge for this part of the county and in the north. We need to be very clear and make sure that we don't squander that money on consultancy up front, trying to do the governance to death, albeit important, and we focus it on engaging and delivery so that we have a delivery first focus rather than making sure everything looks great on a set of slides and on paper. And I think that is going to require quite a significant mind shift. Otherwise, we will have spent millions of pounds and not started delivering. So I think we've got some real opportunities here. We need to make sure that we really start to focus on the delivery point, and clearly the cost out agenda is going to be very challenging as well.
Okay. The board at Kettering yesterday was also, as you know, quite critical of this report. And I think they suggested things that happened, some of them happened anyway, and they didn't really happen because the board had set them as priorities. And I think they saw this paper as you did, rather lacking in data and numbers and everything like that. And so Becky's right in the sense that each of these metrics should go in detail with hard numbers into the committees that will see these topics. That is important. But what was also the point made yesterday, and I think you either should agree with it or not agree with it, because it would be better. These are group priorities. Was and we made a lot of noise by launching these when we did, and therefore we should clearly report back to our staff, Governors and Kettering's case, public, on progress to date on these in a hard numeric way, in an accurate, not in a not in a hard assurance type way about it. I think the other points that have been made here are that we're clearly heading into, however difficult this year is, we're really heading into a much more difficult year next year financially, which will clearly produce a great responsibility on the board to set priorities within priorities, real priorities that you have to focus on. And going back to the comment that these things didn't have to be costly, was particularly set as well. So the important point is that when the board sets whatever it says in its collective wisdom as their priorities for next year and what we really want done, that has to be what the organisation focuses on. And we all have to accept that we have a sacred cow of things you wish it's not in the list, it's not in the list. It's going to be a very hard year. It's significant, as Debbie said, focus on money out, reductions in costs right across the board if we are going to fulfill the ask that we've talked about in the plan. So hard edge stuff into each committee and bring together a report, presumably by the next public board in April, that you can endorse as going out to staff to say this is what we said we do, this is how we did. Okay, thank you very much. And I'm sorry, I should be cross that. That was partly led by Kevin. Are you all right with that, Coach? Yeah, okay, thank you. And integrated care partnership strategy, Karen.
This paper sets out the final version of the integrated care partnership strategy, which is brought here for to note and to endorse. We've had earlier versions through board development sessions, and we've obviously contributed to this. This is a system level strategy for our ICS. It's a 10-year strategy setting out our ambition for our local population to live their best lives, and it includes the 10 best living best life ambitions in here. As I say, it's a 10-year high-level strategy for our system, and it's been developed in partnership with multiple agencies and voluntary sector, community engagement groups, etc. And we've obviously been integral in developing it. The main thing is just to note that the strategy will be underpinned by the outcomes framework and by a community engagement framework, and also will be supported by delivery through our operating model as an ICS, which is very much focused on delivering at place and delivering through our collaboratives, all of which is emerging and evolving as we speak. None of it's finalised and fully working as yet, but there's a lot of work ongoing. There's some real progress in some of the place areas and also in some of the collaboratives. So I think the key point to note is that for us is really what happens next in terms of in particular those comments around actually how do we translate this and bring this to life and to really focus on delivery and turn this into delivery. And that will be done through the health and wellbeing boards are mandated to have health and wellbeing strategies, which are delivery plans to support delivery of this, as is the ICB, a 5-year plan, which will be supporting delivery of this, and then our operational 1 to 2 year plans. So it's really about taking the strategy and then turning it into actual deliverables within the context in which we're working. So really just putting here for any further comment, but it's as I say, this is the final strategy. It's here for endorsement for us as part of the ICS.
Okay. Rachel and then William and Joe, and then see what else.
Can I just ask you when we're going to see the next layer down in terms of planning? When are those plans going to come through?
So the ICB plan is due finalised on the 30th of June. The health and wellbeing strategies, I don't think I'll have to come back on the exact timescale, but it's within the next few months in terms of the finalisation of those plans. So we've got operational plans, obviously. So you've got the strategy, then you've got your ICB 5-year plan and your health and wellbeing strategies done at the end of June, and we've also got our operational plan, which is the end of March. So you can start to see there's a lot of work happening now in terms of delivery.
I guess my concern is that they're not going to be quick enough to actually make inroads next year, but that's just a concern.
Yeah, I hear that. I think from a 1-year operational plan, obviously it's just the start. This is a 10-year strategy.
I get, yeah. Thank you.
Joe.
Thank you. I mean, I suppose along a similar theme, fabulous words here.
Yeah.
Has it been costed? Can we afford it? And I think because it seems back to front to produce a fabulous strategy and we decide afterwards we can't implement it. If that's the question, has it been costed?
And the answer is no, it hasn't. No, this is, and that's exactly, this is a high level ambitious strategy. It's actually around realistically what that means in terms of translating it and what can we deliver by when over the coming years. So that's something we will be doing as a system through the health wellbeing awards and the ICB. But that is something particularly that we're talking to as we've been developing on it.
As I say, it seems a bit back to front really, because we can produce a strategy, but if we can't deliver it because we can't afford it, then that's disappointing to everybody, isn't it?
Yeah.
Just one of the things we have worked well across the system, a really good chief operating officer and director of adult social care group weekly across the board. That feeds into the system chief execs that we regularly, and that's how we've enabled a lot of the changes I've already talked about over the last year. And when we look at the evidence base actually a lot of the gains we can make now is actually in the community and population health. We talked to public health consultants there quite a lot. And it's interesting when you look at it across the board, the highest, the lowest elevation areas also score the highest for crime, also score the highest for the tendencies in Ireland, and so on and so on. So there's some specific areas we need to focus on. And I bring it up because it's not, I don't see this job or any of our jobs as NGH. Actually, I focus with the West as San Fe and the North and the community care around how we make some of these changes, because we've asked urgent care, what can we do? Actually, there's very little you can do for them in urgent care. We can give them better beds, we can give them a better screening help, but all we can do is enable them to deal with the symptoms. Going back to the causes, another issue we've spent a lot of time looking at, we are pushing people out the back door for discharges, social care, instead of enabling the urgent step-ups. So we're rightly so, the symptom is here, the canary in the mine is sitting here. But actually, if we enable more step-ups beforehand, and got better at that social care side, we wouldn't have this problem in the back. So I think if we don't get involved in this as a trust, but also the system, it's one of the keys, but it's about evidence-based decision-making, the data it comes back to. ASIST is able to present back to me our data far more powerful than I can ever get into. And that's from data we produce, we send it nationally. And there's some fascinating insights from, you can see already in our acuity to deprivation index, and how we are treating people from different areas. Are we providing equity to deprivation? Are we providing equity to age? All this other stuff. So that's stuff we're really going to try and focus on internally this year going forward on social media.
Thank you, Alan. Actually, my question was really about what you mentioned, health inequalities, because we monitor lots of metrics in our IGR, but we don't have a dialogue at the board level about health inequalities. What if there's some KPIs like waiting time, referral to treatment, or cancelled outpatient appointments show us these inequalities? So it's not a suggestion. It's something at the level of feelings right now rather than hard suggestion. But can we think what metrics we should really monitor to keep an understanding about the size of the problem, which is within our hands to address?
One of the asks from, I think it's was to look at the GIRF data and the national data around what's coming to the door. So we have had them present back to us, and they are presented to the whole trust next week, I think, around some of this stuff, because it does show we do have some inequalities of care to our elderly population, for example, and also to our to certain areas. So there's some positive bias we should be giving to some areas, and that's one of the key indicators, key things we're looking at this year. What do we need to positively bias towards to enable us to make huge change in that and to level out that?
But just to add on what Palmer has said, I think the key for success of our internal strategies of cardiology, cancer, etc., depends on what this strategy delivers. Because in the front end, whatever we do has got a huge impact on the success of our internal strategies. So I think it will be important to understand the prioritization year on year to and what is actually linked with our internal strategies rather than doing something which is separate based on the costings, which is critical. Linking these strategies is extremely important.
We started to do that with cardiology. So from a cardiology perspective, that's already a system strategy, and we're looking at the system prioritisation of that. So we wouldn't be doing that in isolation by any means, but absolutely it's about prioritising these initiatives that will enable us to deliver those strategies, and we're part of that. So that is the
Okay, well, we've had this before. This is the final endorsement, but I guess that the comments that are made is, yes, it's a good strategy, but we're concerned that it's a strategy without funding stream, and that is not a happy place. And we know quite rightly local authorities are struggling with leisure centre budgets, the children's centre, children's trust is financially overspent, and so on. We just caution them to be focused and realistic in what they try to achieve year on year, this particular plan. And we are particularly keen to tackle the upstream stuff, the electric collaborative ones who tried it, and ICANN ones. We are particularly keen to do that. But if you think about what you need for cardiology or for pre-treatment of cancer or fitness, I think it's a kind of sense that we need the system to think very carefully about what it's committing to. As Rachel said, the next level down, what are you actually doing? Please be extremely realistic for what you do. Otherwise, I think we will just say it's not a strategy. Okay, thank you very much. Group More Insurance Framework, Richard.
Thank you, Chair. So, colleagues will recall that last year we did a lot of work on the risk management strategies and policies at NGH and at KGH, delivering an equity approach. And so what you see before you is the quarter 3 review of those risks framework that are linked incidentally to the paper that Becky presented, priorities across the group, one of the risks to delivering those. So as an aside, I would say that as we get through that process in committees in February, bear in mind that there's a short leg back to these risks. But what you see in the papers is the kind of fruition of that risk management strategy and policy work across the group, in that we have been able now to link directly those risks in NGH's corporate risk register and KGH's corporate risk register, which by necessity are separate entities, into how they relate to our delivery of strategic risk in the board framework. That's laid out in the paper here, and then just to summarise that the committees that met last week have started, the digital committee started the work on the deep dive schedule, the board's agreed, spent a really positive, good amount of time, had some good dialogue, but realised that given that we now have this extra layer of detail, we do need to spend more time on it. And so I made the recommendation to the finance committees, the common and the policy common last week, that we do that work out of session. Spent about half an hour of a 2-hour committee and didn't get to the level that we needed to. So really positive engagement. It's not a negative thing that we're doing it in a different way. It's a positive thing because we're getting that much detail. So other than that, just to say that the report identifies those risks that have been updated by specific leads. They have been through the committees this cycle. That is taking questions.
Okay, thank you very much. You should be familiar with this. It's gone through all the committees in the January cycle. Hopefully accurately, presumably accurately, what they would use the current risk level is. It's finally been through the audit. Any comments or notes? Are we all happy with what's come out of? Happy? Okay, thank you very much. Any questions? SFIs, John.
Yeah, so quite a simple update. This has gone through the audit committee, comes with the audit committee's endorsement. There are essentially a number of track changes in the document that refer to updates on procurement rules and procurement terminology. So just for colleagues that were at the Kettering board yesterday, this isn't as full and complete as the one at Kettering, for the reason being that a number of the changes that were presented at Kettering have already been amended in the NGH SFIs. So looking for endorsement on that.
Okay. Yeah, everybody's happy. Appointment of non-executive director to the digital committee to appoint an FI house. Thank you. Thank you very much. Questions from the public? Don't go any other business? No. Okay. Thank you very much. I now ask the board to approve the resolution of representatives present, public, fellow members of the public excluded for the remainder of the meeting. I'm in the order of confidential interest. Fantastic. All happy? Yes. Lovely. Thank you very much. This meeting is now closed, and if you could vacate the boardroom and move down to the crypts. We are early, and I'm not giving you time off because I think you'll talk. We'll need longer in the private board, so we can make it there reasonably quickly and not assume that we're not going to start down there. Because we are going to start as soon as we get there. Thank you very much. I think we'll take it out. It's about 56. Depending on how lively it is. It felt like 3.5 hours.
I just like, I just